Welcome to Season 13 of the Regimen podcast. Joining us today for a compelling discussion about the future of the pharmacy profession is URI College of Pharmacy Dean, Dr. Kerry LaPlante. Hello friends, today is Friday, May 3rd, 2024. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues and their solutions. My name is Russ Scarpa. I'm a 6th and final year Doctor of Pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg and the Rhode Island Department of Health.
And I'm Jef Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the academic collaborations officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
We're here with URI College Pharmacy Dean, Dr. Kerry LaPlante, an international expert in infectious disease and antibiotic stewardship, educator, scientist, and a leader in pharmacy advocacy.
Why, thank you for that nice introduction. I am very honored to be here with you today.
Thank you for joining us. First part of our conversation is going to be about reimbursement for services rendered by pharmacists. We had our Rhode Island House and State Senate bills heard in committee just this week. What does that really mean, reimbursement for services?
Yeah, that's a great question, Ross. So reimbursement for services already rendered, not expanded scope, which perhaps we'll get to in another time. Those examples include investing time with your patient to review complex medication regimens, providing extensive patient education, comprehensive medication reviews.
A lot of this issue stems from the fact that pharmacists are not federally defined as healthcare providers. This feels like a formality that should have been written into law 50 years ago. I mean, after all, wouldn't most people say pharmacists provide healthcare?
I totally agree. First I have to say why I wanted to do this. Being a pharmacist and advocating for pharmacy is in every cell of my DNA. And I hope by the time I retire, whenever that time is, that pharmacists are acknowledged for the care they provide. And we should be reimbursed for the services we've already been providing, just like our colleagues are.
Yeah, I agree. I think it's interesting there's a movement towards a standard of care model, and there are states that have done that for pharmacists where they say, you have the training to provide this care, and insurance companies recognize that, and they pay pharmacists for those services that are provided.
Yeah, and there's a lot of talk about the primary care shortage in the U.S. on that note, and pharmacists are qualified and licensed to help close this gap as they currently practice.
So if insurers were able to reimburse us for these direct patient care services, drastic expansion and implementation could occur both in clinics and community pharmacies, empowering us to fully serve our patients. When the VA did this back in, I think, 1995, they saw pharmacists successfully manage 1/3 of primary care visits, save primary care, 20 minutes per patient. And there's an additional data from American College of Clinical Pharmacy, which talks about for every dollar spent in clinical pharmacy services makes $4 per patient.
It's a good deal for anybody involved. Separate from reimbursement for services, pivoting now, is prescriptive authority. The United Kingdom just implemented its Pharmacy First program. The idea there is that you can reduce emergency room and general practitioner visits by having people go to the pharmacy first.
Yeah, so as a public health pharmacist who sees community pharmacies as an underutilized node of both healthcare, clearly there's medications there, there's vaccines there. Pharmacists provided more than 50% of all COVID-19 vaccines, both in pharmacies, long-term care clinics that we all worked at. It's very difficult for people to access their healthcare, and pharmacies and pharmacists are visible, accessible healthcare providers. 89% of all pharmacists are accessible to people within 5 miles of where they live. So I think, Russ, we're training you to choose regimens, and those same steps that go into choosing a regimen, really the final step is, and here I'm going to prescribe this drug. So again, when we go back to payment for services, there's a lot of service that we provide in AmCare clinics and inpatient settings where we're providing all this advice. It's saving money, as Kerry said. So it makes sense that we should screen people to refer them either for services rendered in the pharmacy and be paid for that service, or to say, well, we need to refer you to care because so many people are not getting that care. So for example, pharmacists in the UK can now assess and treat 7 common conditions. And I think we've all had this experience. I remember when I had a sore throat, I had to wait 2 hours to go to an urgent care, only to have my primary care go, hey, Jef, you're an ID specialist. What should we give you? And I'm like, why couldn't I just have gotten my penicillin shot at the pharmacy, right? So it's sinusitis, sore throat, an earache, infected insect bites, impetigo, shingles, and uncomplicated UTIs. I've been teaching UTIs for 20 years. I always have a slide to say, in Mexico or Portugal or other countries you go in, you say you have a UTI, it's a screening process, and you leave with medications. It's really, again, and a referral for any kind of consequences or complexities of the medications or the disease that if it progresses. So, Kerry, how does this compare to test-to-treat policies in the United States?
Yeah, that's a great question. So, I refer to these as minor ailments, and also being an infectious disease pharmacist for the past 20 years, I want to pause and just acknowledge the extensive training that our pharmacy students have. Jef, you and I, we went to school for we had 10 years of training at least between, right, each of us. I had my undergrad, I got my doctor of pharmacy, then I did 2 years of additional training in infectious diseases. Our PharmD students spend 6 years training, and then oftentimes an additional year or two. So there is no question whatsoever about the quality and the extensive hands-on clinical training that our pharmacists have. They are more than qualified, and if you speak to any, nurse practitioner, physician assistant, they're the first ones to advocate for how helpful we are. And we train our pharmacy students to be medication utilization and safety experts. And, I teach in med school and have been doing it for many years, as have you, Jef, and, outstanding training. But I come back here and I see how our pharmacists are trained, and we, from medicinal chemistry to pharmacokinetics to pharmacodynamics to drug-drug interactions, we are the medication experts of the healthcare profession. And I would even say, it's of my opinion, that minor ailments are, that's easy stuff. That's per protocol. We do so much more. And it's about time for us to be reimbursed for the services we provide. It's about 40 years too late.
And I think what's interesting, just to emphasize a point made earlier, is if you're saving time for the current providers in the healthcare system by taking care of these minor ailments, it's more convenient for the patient, it's more professionally satisfying to the pharmacist. There's many students who are learning under those pharmacists and going, this is, we're going to talk about roles in a little bit. They see what this role is to say, wow, you saw this was a minor ailment, you provided them treatment, everybody wins. And then there's more time to deal with more complex things, and it goes back to the pharmacist as both a treater and a referrer and a screener in a community setting or even in an ambulatory care setting.
And just to clarify another important point, reimbursement for services does not necessarily mean prescriptive authority. We do tons of things already in the community setting and in the ambulatory care setting and in the inpatient setting, where reimbursement would just mean keep doing these things, but now the pharmacy gets a monetary reimbursement from the insurer for that, so we can dedicate more time and more resources to doing this for more patients.
I've got a follow-up, though. You know what we're going to hear? We're going to hear, doesn't that increase premiums for everybody if we start paying a whole different subset of person? What do you guys say to that?
Well, the first thing I would say is ambulatory care pharmacists currently practice with their salaries being paid out of the savings they give their health systems when they work and manage pharmacotherapy.
Right.
When you have the experts manage medications, you save costs on adverse drug events, multiple drugs being prescribed for the same thing, some drugs chasing side effects of other drugs, ER visits, follow-up visits that you might not need, and also you can see a pharmacist a lot quicker than you can see a primary care provider, so you're getting patients in the door sooner, preventing complications getting worse and more expensive down the line.
And I'll add, when you talk to any of our primary care providers, at least here in Rhode Island, they want this help. They are overwhelmed. They don't have time. Every conversation I have, and I have a lot of them, they're saying, yes, please, I want a pharmacist in my office. And I'll pause and say, my dream is to have a pharmacist in every single primary care, urgent care office to provide, whether it's comprehensive medication management, education, an extensive array of services, because as you know, we have family members, think of yourself, grandparents, aunts, uncles. So many people are on 10, 12, 20, 30 medications. Oh, yeah. It's overwhelming. And the pharmacist can coordinate the care and the medication from the cardiologist, the endocrinologist, the oncologist. Now, that's what the primary care physician is supposed to be doing. And they should see the patients and they should review them. But when it comes to the comprehensive medication management, that needs to go to the pharmacist. And we can do it, but we need to be reimbursed for our services.
Right. How many times have we heard, I had a colleague in an organization where they're like, we really wanted to hire a pharmacist, but they can't be paid for their services. We hired an NP because they can bill.
All the time.
And with sort of a regret of, we'd really like that expertise. This was sort of implied. There's a pharmacist, one of our grads, who works in my primary care office, and every time I come in, he knows I'm a pharmacist. He treats me, just like any other person, but he'll leave. He's like, I'm just so happy that I have this pharmacist. She's so valuable.
They do. They get it.
No, that's awesome. So currently in Congress is the Equitable Community Access to Pharmacist Services Act, which would establish Medicare Part B reimbursements for those test-to-treat conditions we were talking about before. COVID-19, influenza, RSV, strep throat, including and going beyond administering vaccines for those conditions, testing, and treating for them. Also in the Congress is the Pharmacy and Medically Underserved Areas Enhancement Act, which would enable pharmacists to deliver Medicare Part B services beyond that are already authorized by their respective state laws. That's why it's so important to start from the ground up, like we're doing here in Rhode Island, lobbying and testifying and working with students and professors and local practitioners to really get the mission across that we are here and we're available to help. All we need is the paper authorization. We already have the license. We already have the education. We already have the training. We already have the ability.
And very importantly, we must mention Chris Federico, president of the Rhode Island.
Friend of the Regimen podcast.
Friend of the Regimen. But he leads the Rhode Island Pharmacy Association, and that's the state association does a lot to lobby and advocate for these things. But it's interesting that the federal government or the federal folks who introduced this bill know that there's great things happening at the state level and want it advocated for especially those patients that Kerry talked about who are on Medicare, who are on an average of 12 medications each if you're over 65 in this country.
Yeah, absolutely. And, this may be a good time to talk about my experience at the VA, right? So the VA is the largest healthcare system in the country, 153 hospitals nationally, and they have a rich history of recognizing the pivotal role of pharmacists across all clinical settings. As I mentioned before, the national policy started in 1995 authorizing pharmacists to prescribe medications at the VA. That's a long time ago. VA has continuously expanded their responsibilities. The updated document in 2024 increases the services and the scope of practice even more.
Absolutely. So outside the VA, if we were to get similar practice models implemented, we know that in the community we talked about test to treat, that could be implemented quickly and easily. And then on the AmCare side, we could vastly expand these clinics and reach more patients to facilitate chronic disease management. And on the inpatient side, we could even see pharmacists sharing more of the clinical workload, like how some emergency departments have pharmacists follow up on urine cultures after patients leave to adjust antibiotic therapy and not require another healthcare encounter.
That's exactly what our fellows do. They do that. They've been doing that for about 12 years.
In December, I presented with a colleague from the VA in a rural part of Wisconsin who, as soon as the X waiver, which limited pharmacists' ability to prescribe, and she's like, I am now doing the same work as my psychiatrist. Mm-hmm. And she's in person. She meets them. She does televisits. She does follow-ups. But she goes soup to nuts, screens them, prescribes it, manages it, tapers it. And there's hundreds of VA pharmacists that now have the ability to prescribe medications for opioid use disorder in an era where we're not seeing more patients getting access, and when only 1 out of every 5 patients who needs it is getting it. These are very, very clear gaps that we need to close.
Yeah, and I don't know if I could put this back on you
Sure.
guys, but this all feels like a no-brainer here, right? Maybe we're drinking our own Kool-Aid. We're pharmacists. We know what we can do. We've seen it. We've lived it. We've breathed it 20-plus years. What do we think? What is the holdout? Like, what is the barrier to this? Because what I see and what I don't know how to fix, and much smarter people than me have been trying to figure this out, is to dislodge the thought process of a pharmacist being behind a bench, dispensing medication, and then going back to fill the next script. I think there's an unmet need, understanding, educational opportunity for the public to see that that's the face of the profession, and our amazing colleagues in the trenches are doing a great job. But there's just so much more. We're perhaps the most overtrained, underutilized healthcare professional.
Well, so let's talk about, I'm going to start from the 10,000 foot view. We mentioned 2 examples of your fellows calling people to follow up on their cultures or their medications, or community pharmacists saying, how is that new medication, or are you having any side effects, how would you like them managed? Or the pharmacist I work with saying, how are you doing on your new addiction medication? How are you feeling? What's going on? Or my father, who has diabetes, and he has a diabetes pharmacist, which he just sort of casually says as if that's what everybody has.
Love it.
And I'm like, well, I don't know anything about diabetes, so I'm glad you're not telling me anything about that. We have our lanes. But this idea of, if every patient got a separate call from their pharmacist for some reason,
the dream.
As the medication experts, but why isn't that happening? Because it's kind of a catch-22. It's like we need to get paid to do those follow-ups, which actually save money and in the end, and get more pharmacists to do those calls. Right? We have a very robust specialty pharmacy model where rare diseases with very expensive meds absolutely prove their worth. Patients love it.
Again.
So, but that's a small subset. If, I don't know, 75% of people are like, oh, I get started on a med, and a pharmacist called me about it, that's what's going to change public opinion, and that's what's going to change these kinds of policies, I think. I don't know, Russ?
That's a great segue into our discussion of the barriers, first of which I think is pharmacy's PR problem.
Yep.
So we have a very, very diverse array of identities, both internally and externally. There's a great paper that I love that I sent to Dr. Bratberg a couple weeks ago to read and report back to me his feelings on.
Did he read it?
I did.
Not sure if he did.
This time I did.
He says he did. So they broke down these different roles throughout the history of pharmacy, where you have the apothecary, which is the classic mortar and pestle, Romeo and Juliet. You go see this person, and they give you an assessment, and they give you some sort of a
You're telling me we started
concoction.
out prescribing and dispensing, Russ?
Well, we can go back to the
Edict. It's a Wonderful Life,
yeah,
right?
It is.
Yes.
Yeah.
Exactly. Go back to the Edict of Salerno in 1241 AD. Anyway, and then there's also the dispenser role, which we saw more in the 1950s, where you have the pharmacist in the white coat behind the counter, your classic.
Part of the community,
yes.
where Kerry
Integrated.
started with, and her...
It's first job, 16, and an independent pharmacy.
Love it, with the soda fountain.
No soda fountain, but 34 years I've been in pharmacy, through independent, CVS, all of them. But yeah.
But you talked about it being part of that community, and this person...
it was a huge part of our community in Buffalo. Yeah, that was primary healthcare, service. They would come to the pharmacy first, and we would refer them to the emergency department or wherever they needed to be. Yeah.
Right.
Yeah.
You're the point for healthcare.
Center of the community. Yeah.
I love
Dunn's Pharmacy, South Buffalo, Seneca Street.
There
Love
it is.
it.
We'll post a picture.
Yes.
Shout out to Dunn's. And then there's been this transition from the dispenser to the merchandiser, which is your modern chain pharmacy sort of an image. And then flipping that around, we have the inpatient side where you're starting to see the expert advisor role, which is how you always practice, Jef and Kerry, where you're the consultant, the expert on the team, and they're happy to have you, and you provide immense value. And then this new area that we're sort of been pushing and exploring is the healthcare provider role. Your pharmacist in these ambulatory care clinics, managing the medications themselves, delivering incredible, stellar outcomes. And then tying all these different people together, they have common traits. They have strong characters, they're scientists, they're advisors, they're clinicians. These are self-identified traits that matched across the board. So that leads me to ask you, Kerry, what is your identity as a pharmacist?
Or is it even listed there?
I didn't read this paper, but I'm pretty impressed. So first I have to say my identity as a pharmacist, I have a servant heart. I want to serve. I want to help. Again, since my very first job in a pharmacy, and clearly I never left, I do believe that this profession is a calling for me personally. I can't imagine doing any other career, and I mean that. So my identity is a pharmacist. As I said, being a pharmacist is in every cell of my DNA. That is who I am. And a proud pharmacist. And why I loved infectious diseases and why I love pharmacy is, I helped my team. When I was rounding at Henry Ford Hospital back in the day, Jeff, you were there. We were on the team. The team wouldn't round without us. They were calling us. And we were the medication experts. I remember all the time, MRSA infection, pharmacy to dose, drug dose duration. Those were the orders. It wasn't anything but that. And this is in 2002.
Yeah.
My first patient that I took care of was a double lung transplant patient. I was a student managing her aminoglycosides every day for weeks. I was in charge fully of the medication of those patients. And the pulmonologists, they loved it. They didn't care. They didn't feel I was stepping on their toes. So it goes back long. It's a calling for me, and I absolutely identify as a pharmacist and couldn't imagine doing anything differently.
I like that. It's interesting you talk about Henry Ford. My first patient was a triple transplant in 1990.
It's not a competition.
It's not.
No.
It completely. I'm not the boss. Let's be very clear here. No, but I remember the same thing, like seeing this, just sort of like, look what healthcare can do. Yeah. The surgeons can do this amazing, amazing thing. This person's walking down the hall, and I just remember him saying, he's like, oh, are you the pharmacist? I'm like, I'm the pharmacy student. Mm-hmm. And they're like, oh, can you tell me about, my steroid dosing? What's going to happen? And like, I can help this actual person who spent 15 hours in surgery 2 days ago and now is walking around. So I think there's...
And the team wanted you. They're like, you go.
Absolutely.
Do it. Yeah.
Oh, yeah. Because that's... When I'm teaching or serving or at testifying, it really comes down to what do people need. So it kind of goes back to your question of like what's preventing us. And Russ said it's a PR problem. Yeah. The public has to view us in a different way, but they're not really seeing us as an expert advisor. We need to call people. Mm-hmm. They're not seeing us as a healthcare provider because, but they are, right? We give vaccines, we get tests to treat. Their tests are like COVID's done a lot. So what's your identity? You have this question about like, can we have multiple identities? I think we do, and I think we've come full around. I kind of joked about it, but the apothecary is, tell me your problems, screen those problems, here's my recommendation, and I give it to you. I very clearly remember rounding where they said, what does this person have? I looked at their cultures. I said, I'm just going to grab some antibiotics, and they said, sure.
Go for it.
I literally made them, brought them, handed them to the nurse, and they're just like, do you want to connect up the line? I'm like, sure. And I like soup to nuts going, this is just normal. And the resident's like, thanks. I got other things to do.
Right.
We relieved time.
Looking
on
at the
team.
X-rays right now.
Yeah, exactly. Yeah. And I can't read those.
This was on F2, Jeff. It was
pulmonary rotation. You remember what it was? Oh, I don't remember.
Yeah, it stayed with me.
Wow. I remember you actually telling us that story about your double lung transplant patient when you told us infectious disease, which for me was like 3 years ago.
Yeah.
So your story stuck with me.
Thank you.
How do you like that?
Yeah. So what's your identity, Russ?
What's your identity?
What were you taught? That's your question.
Do you have one yet? Because you're so new?
I have some semblance of an identity. Okay. So I actually reflected on this. Jeff asked me, after I made him read that paper and report back to me, he flipped it back on me and asked,
That's
Russ.
What a professor does.
As he did. He said, so Russ, what's your identity? And I sort of pondered that extensively, and I really decided that myself, I am an independent healthcare professional. I think that's important to put in here. With an acute awareness of the nuances of medicine and their uses for the treatments of disease. That's what I came up with. I wrote it down on my phone to tell them the next day. Because I really think that's our role. It's like you said, the experts in medication therapy. Because when we say, like, what's our unique identity, what are you doing that no one else can do? That's what I'm thinking about.
That's exactly it.
And it's those nuances. Anyone can pick an antibiotic out of a hat and throw it on. But is it the right one?
That's actually how it's usually done.
That's exactly how.
Despite Kerry's 20 years of effort to...
Yeah. Well, I mean, you have to know so much. As a provider, you need to know so much, right? And I don't know, but to have different expertise to all augment each other, and I have to throw the synergy out there, like to synergize. We all have roles. We work together. We're inclusive. We're interdisciplinary to provide the best care for our patients. And if I can go on a tangent, you can maybe delete this if you want. A story to tell. So I just got back from Barcelona on Saturday, and I had the privilege of my husband and I to go to a 3-star Michelin restaurant. Oof. It was one of the greatest experiences. So, yes, my wedding and the birth of my children, and then this experience.
And if it was a 4-star, it'd be better.
There is no 4-star. 3 is the highest, right? Lifetime experience, or excellent. So, and I'm sitting there, and because I'm a pharmacist, I'm at a scientific meeting. I'm at ICMED, and I'm looking around, and the staff, and the service, and the care, and I did, because I'm so nerdy, I thought this is what healthcare should be. This level of care and detail in this amazing restaurant is what all patients deserve. And then briefly, I'll reflect. My dad had cancer in 2019. It was lung cancer. He didn't make it. We took him to Roswell Park in Buffalo, a phenomenal cancer institute. You pull up, and it's in the city of Buffalo. There's valet service. That you walk out, there is music, there are flowers, there are Girl Scouts singing, you get a buzzer, you check in, And they concierge you through that place. And this is a cancer institute. People are dying. It is probably one of the most beautiful healthcare systems I've ever been a part of. The pharmacist is involved. My father knew who that was. And I make this analogy both with this like 3-star Michelin restaurant and the quality of care that my father did get at Roswell Park in Buffalo. And this is what we all strive for in healthcare, this level of quality for everyone. And pharmacists are a key part of that.
It's a phenomenal story. Yeah, it's interesting. I always think about European, single-payer healthcare, and you go, yeah, I've experienced the Australian healthcare system, and I was in the UK healthcare system, and even in the emergency room. And
do you just keep getting injured when you go abroad?
No, these are people with me. They can't keep up.
Love it.
Leave it in. So it's this interesting thing where I'm like, we're in the accident and emergency, and I had spent basically no time in the ER, and like, it was just a different, it wasn't Michelin star level, but it was like, okay, they have single payer healthcare and they just treat everybody equally.
Yeah.
And I think that's the other sort of underlying thing is, I have these conversations about addiction care all the time to say, doesn't everybody deserve the same care, like the same baseline of care?
Absolutely.
And if we provide baseline care to everybody, we actually will create time and money to raise that baseline to the level you're talking about, that everybody does deserve.
And good communities take care of their most vulnerable first.
Right. And not because they're vulnerable, but because they're people.
It's just the right thing to do.
Yeah.
It's a dream, and we need to get there.
Going off that, it's, the servant to the public that you're just talking about right now. As dean, what sort of core identity would you like to see students graduating this program with? As pharmacists, what is their role? What is their mission?
Thank you for asking that. That's an important question, and I think about it often. Just last night, I got a text from a colleague at the CDC who is with a student, one of our students now, and the text was, "What an exceptional student this is." I can't tell you how many times we are told how exceptional our students are. And I'm a bit biased, but I've been hearing it for years. So I'm so proud of the students we have and their character and their knowledge and their insight. So with that comes great responsibility as dean. I can't mess that up for our students. They're amazing. They represent us. So my vision is an interdisciplinary model, of course, with our amazing physicians, nurse practitioners, physician's assistants, is together we advance health and transform communities.
That sounds familiar. What's that from?
That is our vision.
Okay.
Of the College of Pharmacy.
Excellent. Building off of that, we want to hear more of those stories from our phenomenal students. Where do you see pharmacy in 5 or 10 years?
Oh, that question's for me. As I say, I'm 10, 12 years out from retirement, and I will say this.
So what's pharmacy going to be like when you're retired?
I hope, and I will say, taking this role as dean, it is a platform. I've never been a title person. I've never strive for more in that sense, but the sense of duty and the platform as dean to represent pharmacy at a national level is really why I took this job. So what is pharmacy going to be like when we retire? Russ will be leaving, in your good hands. My vision is that every patient who is on multiple medications has direct access to a pharmacist that can manage and do comprehensive medication management, coordinating the care of all of their physicians and making sure that their medications are optimized. And we'd be reimbursed for those services.
That is the key. I think reimbursement is a huge first step to help make that vision a reality. Definitely make it more sustainable and let us to reach a lot more people. And I guess really that's how it would benefit our communities. That was our next question, but...
Yeah, I mean, if we were just saying, we're servant leaders. We, again, all three of us literally spent our Thursday night talking about and really educating, sort of what we talked about earlier, educating the policymakers who represent the public to say, look, we are already doing these services. I'll just, we talked about the hearing. It was interesting. We were asked when Kerry and I were up there, we were asked this question of, well, how do you separate in a community the question about a medication or an over-the-counter med and when it's an actual visit? And I thought we answered the question pretty well to say, well, how many of us call our healthcare provider or the nurse line for some random question? They say, oh, it's a rash, it's probably okay, you don't need referral, or yes, this is a visit, and I'm going to go look at my protocols to determine what it is, and you leave with medication today, or we're going to go call our transportation, and you're going to get to the emergency room, like, which I've done. I was telling Russ a story about the woman who came to my pharmacy on a Saturday afternoon and said, I've been coughing up a cup of blood. But here's the thing. Why was this person not going to the ER?
She didn't know.
She didn't know.
But she came to you.
But she came. She went to the most
Yeah.
successful pharmacist, and luckily I was right around the corner. As far as I know, she was okay. But it was this realization. It was very early in my career to go, wow, there's a lot of learning to happen in the community. So I think the other thing, what helps our communities is every pharmacist has now talked to a person. That person's now talking to a pharmacist, and all our premiums are actually going down, billing for each of those sort of micro or macro visits.
And it's funny you said that, because another aspect of my sort of vision of what a pharmacist is plays into something some professor told me a couple years back, which is probably Dr. LeMay. Pharmacists...
She's awesome.
Also friend of the pod.
Also friend of the Regimen podcast. Pharmacists are this really unique healthcare provider in that we are equipped to educate our patients in such a way that's translating extremely complex information into digestible, meaningful, understandable segments. And that's really a big part of what we do when we're counseling. We're taking, package inserts that look like a map to buried treasure.
Right.
And putting into a couple bullet points that are easy to understand and actionable and impressionable. So, assuming that we just inspired all of our listeners to go advocate for pharmacists across the country.
Yes, we did.
What are their calls to action? Where should they start? What should they do?
It's a great question. And what I would ask the listening audience there, do you have a loved one, or perhaps it's yourself, that is on multiple medications? And I would almost guarantee you've had that thought of overwhelm in figuring out what each medication is, if they should be on it, what is causing the drug interaction, is this a side effect, is this an interaction, can I take an herb, can I take over the counter, can I take Tylenol with this? And I wonder if you're thinking, who could I call for that? And I would love to have a situation where you could call your local primary care provider and talk to a local pharmacist. They can provide that optimal service, and pharmacists would be reimbursed for their time.
And those referrals will be natural in that setting, right?
Yeah.
Where the primary care goes, this is a job for the pharmacist. The pharmacist goes, this
just
is a job
like in
for
the VA.
primary.
This is what happens in the VA.
Just like in the VA, in which we all our tax dollars are appropriated to. So
They're doing a great job. It continues to expand. They're doing it well.
I love it.
Bring us home, Russ.
So in summary for our listeners, pharmacists are, have been, and always will be well-equipped and eager to better serve our communities, and reimbursement for these services would greatly help expand these services. This does not directly pertain to the ability to prescribe medications, which is a separate, although no less valuable avenue through which pharmacists can benefit our communities. And that concludes our episode of The Regimen for Pharmacy, its profession, and its future. Please let us know what questions you have. Follow us on Instagram and Twitter at PharmD.PubHealth. And of course, leave a positive rating and subscribe for more if you found this informative.
Smash that subscribe button, everybody. Thank you so much, Kerry, for joining us on this special episode of The Regimen.
Thank you all.